Today, we're talking about trauma and stressor related disorders in the DSM 5 TR. So, in this section of the DSM, we've got reactive attachment disorder, disinhibited social engagement disorder, post traumatic stress disorder, acute stress disorder, adjustment disorders, prolonged grief disorder, other specified trauma and stressor related disorder, unspecified trauma and stressor related disorder. And the DSM does not include complex PTSD, but I put it on my slide because I do what I want. So, now, all of these share some prominent characteristics rather than anxiety or fear based symptoms like phobias or anxiety disorders. The most prominent clinical characteristics for many individuals who are diagnosed with trauma and stress related disorders are anhedonia and dysphoria, externalizing anger or aggressive symptoms of irritability or dissociative symptoms that checking out dissociation. These tend to span the classification of disorders that we're going to talk about today. And we'll focus mostly on trauma since there's a lot to discuss about the brain and general health impacts, and that will overlap with all of these. But let's start with reactive attachment disorder. So that's the one that a lot of people are familiar with, reactive attachment disorder. It's characterized by pervasive, inhibited, withdrawn behavior towards caregivers, as evidenced by rarely or minimally seeking or responding to comfort. Both of those have to be there. They have to rarely seek comfort and rarely respond to comfort. The second criteria is ongoing social and emotional problems as evidenced by two or more of the following. So, minimal social and emotional responsiveness to others. So, instead of seeking solace, seeking comfort from caregivers, this just means interacting with others in a social and emotionally responsive way, including peers. Limited positive affect, or episodes of unexplained anger, depression, or anxiety, even during non threatening interactions with adult caregivers. Additionally, the child must have experienced inadequate care as evidenced by one or more of the following. So, social neglect, including not having basic needs for safety, love, and stimulation met. Now, I have basic needs bolded for a reason. What our basic needs for each individual child may vary. So, for example, a child who's neuroatypical may have very different needs than a child who is neurotypical. And the parents may not understand the different needs, especially in the infant stages before that child's able to articulate what their needs are. So, the social neglect may not always be as a result of a neglectful caregiver, it could be a result of an unaware caregiver. Basic needs for love. Wow. So some children are characterized by more high needs and others are easier going. And I don't really like those terms, but some children need more assistance with emotional regulation than others do. And caregivers may not be equipped, they may not know how to respond to that. So again, the child's basic needs for love and responsiveness may not be met. And the third one is stimulation. And again, we really want to look at the differences between children. What one child needs for stimulation may be way more than what another child needs. And what some might need might be super overstimulating for somebody who's neuroatypical or has undiagnosed ADHD or even diagnosed ADHD. Limited opportunities to develop secure attachments due to frequent changes of primary caregivers. Now, in people diagnosed with reactive attachment disorder, this is most often the criteria that is met. They may meet all three, but a lot of times when we're looking at the prevalence of reactive attachment disorder, it's not as common as you think. But it is common, relatively speaking, in children that are involved in welfare, children that are in the foster system. If they frequently are changing primary caregivers, going from living with their biological caregivers to a foster home, to another foster home, to another foster home, and back to their primary caregivers, then they start this cycle again. It can be very confusing and very unsettling for the child. And they might just sort of wall off and say, you know what, I can't take it. I can't trust you. You can't be there. I can't trust you to meet all my needs consistently because tomorrow it could just be somebody else. So I'm not even going to connect with you. Or growing up in unusual environments with severely limited opportunities to form selective attachments. And the examples that the DSM 5 TR gave were in reference to large group homes. For example, where there's a high child to caregiver ratio, However, we also look at situations like very large families. Now, they're not the norm in the United States, but they can happen, which the ratio of child to caregiver is 8 to 1 or more. And in situations like that, it's important to recognize that, there are many situations in large families in which the children do get their needs met. So we don't want to assume that, it's just as soon as the ratio changes, but we do want to kind of look out for, does that parent have enough time to give that child the love and support and attention that they need? Now, one of the things that's unique in group homes that, really isn't a primary caregiver, so to speak. So there's somebody on duty 24 hours a day, and they may have a primary counselor, but that person doesn't really serve or fit the same role as a primary caregiver. So we're really looking at an environment in which there's a high child to caregiver ratio, and it's a non-traditional caregiver arrangement. So remember, they only have to have one of these: social neglect, limited opportunities to develop secure attachments, or unusual environments with limited opportunities to form selective attachments. The diagnosis goes on. The inadequate care is responsible for disturbed behavior. So you have to see the inadequate care and then the behavior happening, not the behavior first. So inadequate care needs to have precipitated the behavior. The criteria is not met for autism spectrum disorders, and it will be important to differentially diagnose this because there are a lot of similarities between reactive attachment disorder and autism spectrum disorders. However, people with autism spectrum disorder have not experienced that neglectful environment, and they have had potential opportunities to form meaningful connections, but maybe that's just not something that they've been able to do or want to do. For reactive attachment disorder, symptoms must be present before the age of 5, and the developmental age of the person must be at least 9 months old. So if you have somebody with severe intellectual disabilities, even if they are chronologically 6 or 7, if their developmental age is not at least 9 months old, then the criteria for reactive attachment disorder would not be fully met. I do want you to consider, though, when you look at the data, I use that term extraordinarily loosely because there's very little data on the incidence and prevalence of reactive attachment disorder in the general population. But whether you look at the DSM or you look in PubMed or EBSCOhost, the studies that have been done have largely been done in residential treatment centers. So getting accurate estimates of the prevalence is a little bit more difficult. However, I still think that the rough estimate of less than 10% of children in child welfare will develop reactive attachment disorder may be very low. And this is my opinion here, but I want you to follow me. I want you to think about this. Children who are in child welfare may enter welfare when they're 5 or 6 years old, and we may not know what happened before that period of time. We may not have a good indication of how long that abuse or neglect was going on. We may not know whether that child was exhibiting those reactive attachment or avoidance symptoms prior to age 5 because we don't have a good medical history. The child may have not gone to the doctor, or the child may have gone to a doctor, but they went to random clinics here and there, and we don't really have a set medical record, or we can't count on the biological caregiver to be a reliable historian because maybe during that time that they had the child in their custody, they may have been so overwhelmed with their mental illness or their addiction that they aren't able to actually give an accurate report of what was going on. So my estimation or guess is that the amount of reactive attachment disorder in children is actually higher than what's shown in the books. And if you work in child welfare, if you work with foster kids, I would encourage you to think about, when you're looking at your caseload, how common are attachment problems? It's important to recognize that even if something doesn't rise to the level of reactive attachment disorder or disinhibited social engagement disorder, it doesn't mean that there's not a problem. So, lack of ability to form secure attachments is going to have reciprocal problems for the child later in life. So, on the polar opposite end of the spectrum is disinhibited social engagement disorder. The child isn't lacking attachment, they're sort of pushing it. The child frequently approaches and interacts with unfamiliar adults, as evidenced by two of the following: lack of caution in interacting with unfamiliar adults. This would be like a child walking up to a complete stranger on the playground, some adult stranger that they've never met before, that they've never seen before. It's not Tommy's mom that's been on the bench every week since you started going to the playground. You know that person a little bit and maybe more familiar to the child if it is Tommy's mom, even though they've never met. So we do want to watch how we apply that criteria. The child is overly familiar, uses overly familiar verbal or physical behavior that's not culturally or age appropriate. So they may get hugs, things that are overly familiar. They may use terms that are overly familiar, like calling somebody by their first name or addressing some adult in a much more familiar way than would be considered appropriate. Lack of checking in with their adult caregiver, even in unfamiliar situations. And think about children that you've known or that you've had, some sort of reasonable attachment with. In unfamiliar situations, they will often check back in just to make sure that the caregiver is still there. Go to the playground and they're playing, they may not actively come back over to you, but a lot of times they'll scan and periodically check to make sure that you're there. And it's important to notice if children are just completely detached and oblivious to the caregiver in unfamiliar situations. And there's little hesitation at leaving with unfamiliar people. So, for example, at the playground, a child might walk up to a stranger or even somebody who they kind of sort of know and be like, take me to the bathroom. Or the stranger may say, hey, I've got candy in my car. And the child with disinhibited social engagement disorder would likely go with them. So it's important to explore and evaluate whether the child is just being impulsive, like, ooh, candy sounds really good, or if they have a habit of doing this and going up to strangers and engaging in disinhibited behavior. Behaviors are socially disinhibited, not simply impulsive. And the DSM 5TR does not really define that difference. However, impulsive would be like the kid sees something here and, is tempted by something. And it's like, ooh, I want to have that now. I think we all kind of know what impulsivity is of, I want to pet the doggy. I want to have some candy. I want to go swing on the swings. Social disinhibited is going up to adults without provocation or even with minimal provocation and not being intimidated, not being scared, not being wary at all. It's just like, hey, you're another person. What are we going to do now? And the child has experienced insufficient care as evidenced by, and this is the same for reactive attachment disorder, social neglect, including not having basic needs met for safety, love, and stimulation. Limited opportunities to form secure attachments due to the primary caregivers or growing up in environments that severely limit opportunities to form selective attachments. The care in Criterion C is presumed to be responsible for the disturbed behavior in Criterion A. So the neglect is presumed to be responsible for the behavior. And we want to see the behavior following the neglect. So if the child exhibits this disinhibited behavior, and then the caregiver corrects the behavior and the child doesn't do it anymore, that's not disinhibited social engagement. That's just a kid pushing boundaries or being curious or just not having a good understanding of how the world works. So we definitely want to see the neglect first and then the behavior as a reaction. Now, interestingly, in disinhibited social engagement disorder, and I looked over the criteria multiple times, the child has to have a developmental age of at least 9 months, but there's no age requirement for the first presentation. Remember, in reactive attachment disorder, the symptoms need to begin before the age of 5. But with disinhibited social engagement disorder, there isn't that requirement. So there's not a ton of research here, which is interesting because over the past 20 years or so, there's been such a flurry of attention to attachment that one would think that we would have a better picture of the prevalence of reactive attachment disorder and disinhibited social engagement disorder, but we don't. So it's important to recognize that reactive attachment disorder and disinhibited social engagement disorder, they start in childhood, but it doesn't have an endpoint. So you can have somebody who's an adolescent or adult who's still symptomatic for one of these attachment disorders. Differential diagnosis. Now, the DSM in reactive attachment disorder did specifically say that you have to rule out autism spectrum disorders. Children with autism spectrum disorder or reactive attachment disorder can have reduced expression of positive emotions, cognitive and language delays, and impairments in social reciprocity. Remember back when we were talking about, and I said there's a lot of overlap in the symptoms. What you don't see in is the neglect. And what you don't see is the inhospitable environments in children with autism spectrum disorders without reactive attachment disorder. So you need to rule out ASD. And now it didn't indicate whether you could have comorbid diagnoses if there was a neglectful environment. If the child did meet all the criteria for reactive attachment disorders, could they also have a diagnosis of autism spectrum disorder? Because ASD symptoms also begin before the age of 5 in most children. So I'm not sure about all of that, but it is important to to effectively diagnose because the treatment for autism spectrum disorders is far different than the treatment for these attachment disorders. So trauma, PTSD is one of those very popular diagnoses right now. I think, sometimes we go through cycles of what's the popular one to diagnose, and we're seeing a lot of PTSD across the board. So I'm putting prevalence rates sort of at the top today so we can get a feel of what the research is saying. The APA says PTSD affects approximately 3.5% of adults every year. An estimated 1 in 11 people will be diagnosed with PTSD in their lifetime. Women are twice as likely as men, and three ethnic groups, US Latinos, African Americans, and Native Americans or Alaska Natives, are disproportionately effective and have higher rates of PTSD than non Latino whites. So the likelihood that you're going to bump into this one, regardless of the population that you're working with, is pretty high. So let's actually start off with defining trauma and explore how it might interact with mood and addiction issues, as well as potentially physical health issues. Trauma is experiencing something that overwhelms your ability to cope. Trauma is an emotional response to a terrible event like an accident, rape, or natural disaster. Immediately after the event, shock and denial are typical. Longer term reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. While these feelings are normal, some people have difficulty moving on with their lives. Not all trauma results in PTSD or CPTSD, complex traumatic stress disorder. Trauma, if you have adequate resources and you were not already struggling with addiction or mental health issues, can often be resolved without injury. However, if it's not resolved, it leads to what I call traumatic injury, which is PTSD or CPTSD. People with PTSD or CPTSD often experience re experiencing. They may have flashbacks or nightmares about the event. They often experience hypervigilance. One of the core features of trauma is during the event, you feel unsafe and disempowered. You feel like you don't have any power and maybe not the ability to escape from it. Therefore, after that point, if you haven't resolved it, if you haven't developed a sense of safety and personal power again, you may be what we call hypervigilant. You're constantly on guard, you're constantly scanning because you don't feel safe. People with post traumatic stress often avoid reminders of the event. Well, that makes sense that you wouldn't want to be reminded of that event, but people with post traumatic stress or complex post traumatic stress go to great lengths to avoid these reminders because when they encounter those reminders, it triggers their other symptoms, and that is just so painful and overwhelming. People with post traumatic stress often have what we call emotional dysregulation because they don't feel safe. They're hypervigilant, that stress response is frequently or constantly on. And when that happens, the body, in order to protect itself, turns down your stress response. So you're not going to notice or respond to things that probably would have irritated you before. Your body says, we don't have all the energy to focus on that right now. So we're just going to ignore it. We're just going to let you go. We just don't have the energy. So that person, most of the time, instead of having bouts of feeling happy or irritable or a little bit anxious, they're just kind of flat, like Eeyore from Winnie the Pooh. But when they do get triggered, their body will send this tsunami of stress hormones. So they go from feeling flat to frantic or flat to furious. And that's what we call that emotional dysregulation. They don't have that middle zone. They don't have moderately irritated. They're either flat or they're enraged. They're either flat or they're absolutely petrified. And many people with post traumatic stress also struggle with feelings of guilt and shame about what happened, about their memories, about not being able to move on, about a whole bunch of things. Many people that are struggling with addictions and anxiety and mental health issues have a history of trauma somewhere, whether it's attachment trauma from childhood or traumatic events from when they were growing up or from the past, 5 years. I don't know. But the majority of people that I have worked with have a history of unresolved trauma somewhere. So it's important to think about whether you've experienced traumas, whether some of those traumas are unresolved, and how they may be triggering addictive behavior, depression, anxiety, anger, guilt, grief, jealousy. A lot of what we might do with clients at first is getting them to a place of grounding using coping skills and identifying coping skills that work for them to deal with each of the symptoms that they're experiencing. So when they're having a flashback, they can cope, or when they're feeling really anxious or irritable, they can sort of bring themselves back to a baseline. So So, why is this all happening? The physical response to a fearful or frightening event is that sympathetic nervous system activation of the HPA axis, the adrenal system. I keep talking about this system is hardwired to respond to perceived threats, and that's for survival and protection. If there's a bear that just walks into the room that you're in right now, you should freak out. That response is built in to help keep you safe and pump your body full of fight or flight chemicals to get the hell out of there. Fear can be physical, emotional, or cognitive. The physical piece of fear is that muscle tension and heart racing, the clenching of our teeth or our jaw. The body is prepping for you to move. Your body is getting itself in gear to speed up your heart rate, deliver more blood to areas of your body that need more oxygen or other responses to help you get out of danger. And when that stress is perceived in the body, increased heart rate dilation of our bronchioles, the liver can start to convert glycogen to glucose. We create cortisol, decreased digestion, blood pressure increases, and that's where that fight or flight response comes in again. The body goes into what's called also a protect myself mode. It's that sympathetic nervous system does all of those things in less than an instant. The emotional, it can feel like horror, panic. We can't breathe. There's a weight on our chest, maybe like a panic attack because you are, in fact, panicked. The cognitive, it can cause poor concentration and overstimulation of a threat of what's commonly referred to as catastrophizing. Because we're not planning our grocery lists or thinking about what we should wear that day, our brain is really just focused on what it needs to do to keep us safe. The communication in the brain between the prefrontal cortex and that middle and the back of the brain, the limbic system, and what we often refer to as the reptilian system of the brain in the back, that's the part that's responsible for breathing and existing. So there's tight control of thought, emotion, and action in an unstressed brain. Everything gets jumbled, and there's weaker control of thoughts, emotions, and actions when we're stressed. Oftentimes, we lose control of that prefrontal cortex and we're no longer rational. That's where catastrophizing comes in again, or as I love to say, we're not creative when we're stressed. We don't have access to logical decision making. And even going back to substance use chapter, when I said it feels like survival in the brain, this is the same stuff. Someone with a substance use disorder in survival mode often might do things that appear irrational to you or to me. Our goals, our thought processes are very different. And when we talk about the brain, we also talk about our stress response. And this is an example of a diagram that shows your stress response in your body and things that come through the brain and the hypothalamus. So I want you to take all of these things into consideration as we begin to explore the things like adjustment disorders and start to think about what the lived experience of the person who's going through the symptoms of some of these disorders might be. There can be one major trauma, or it can really be ongoing traumas every single day. The most common forms of trauma resulting in PTSD included the unexpected death of someone close, sexual assault, serious illness or injury to self or someone else, a serious car accident, having a child with a serious illness, a terrorist attack, or a natural disaster. And let's think about this. Normally, when we think of PTSD, we think of something like war trauma or being the victim of a violent crime. But there are a lot of things that can lead to a sense of helplessness and horror in the threat of serious injury or loss of life. And we also want to consider the impact of whatever it is and the age of the person impacted. Something like an unexpected death of someone close may probably have a different impact on someone who's 35 as opposed to someone who's 5. So we do want to recognize that brain development, cognitive development, and just number of years on this planet and experiences may serve to buffer or may actually impair if they've already got some traumatic experiences. Serious car accidents, we want to recognize, and for some people, there are some studies that I read that when people have a heart attack, some people who have a heart attack end up developing post traumatic stress because of the severity of the illness, the fact that they almost died. In complex PTSD, now, this is PTSD that develops as a result of exposure to multiple traumas or repeated traumas over a period of time, domestic violence, child abuse, and we do see complex PTSD in law enforcement, fire, rescue, military. In complex PTSD, structural abnormalities in the brain seem to be more extensive than in PTSD, in which there was a single trauma. And brain activity in complex PTSD is also strikingly different from brain activity seen in people who experienced a single trauma. So, this is ongoing exposure and this is ongoing lack of safety, ongoing threat. It tends to disrupt neural connections and the way the brain actually works in a different way. The amygdala, when it's initially exposed to trauma, increases in size, but over a lifetime, over the span, if exposure to traumatic experiences and stressful experiences continues, then the amygdala really starts to shrink. Right. So if a bear walks in your room right now, you freak out. But what happens if that bear is walking into your room every single day that you're alive? The constant reactivation of the HPA axis is going to start causing some changes. So, we do see that the brain alters its actual structure as a result of exposure to trauma. So maybe we'll think about 2020, 2021. There seems to be an increase in PTSD related to the pandemic. Seeing people getting sick, having people suddenly die, having people that you love have to go to the hospital and not being able to be there with them, having them pass away by themselves. There were a lot of things that happened in 2020 that were extraordinarily traumatic for a lot of people. And it's important to recognize how many ACEs occurred because of the pandemic. Intergenerational PTS. Now, notice I dropped the D off of it. When people experience PTS and it goes unresolved, they may carry forward some of that hypervigilance. They may carry forward some of that negative impressions of themselves in the world, or they carry forward, the PTSD symptoms. Those are communicated to their children. Their children grow up and hearing those messages, hearing how the world is an unsafe place and feeling unsafe and afraid, which can create PTS in those children. Those children may grow up to be hypersensitive or hypervigilant to threat trauma. So, intergenerational PTS and intergenerational ACEs are really a thing. So, it's important that we advocate for caregivers to make sure that they're experiencing symptoms, that they have a way to address them. And then the last one, I know I didn't know what to call it, but cultural PTS. There have been a lot of things that have happened in the last 5 years, maybe even 10 years, that have created a lot of trauma for a lot of people in American culture. And, you don't have to go far on social media to find people who are experiencing a lot of distress as a result of things that are going on in the world: racism, discrimination, economic impoverishment. These can all be factors pointing towards long term PTS. So it is important to recognize that, there is a lot of stuff, and media and social media unfortunately keeps the wound right in your face. We need to help people examine the cultural stress that they may be experiencing. Mood disorders. So, people with PTSD, not surprisingly, have higher rates of mood disorders, especially if they've had prolonged PTSD. Now, that's not necessarily complex PTSD, that's people who've had PTSD for a long time and it's gone untreated. Well, think about what the symptoms of PTSD are: hypervigilance, intrusions, intrusive memories, feelings of unsafeness. Well, if you feel this way a lot, then yeah, it's probably going to contribute to anxiety and depression. That's not really so much of a stretch. And there are two types of responses to traumatic reminders of stress that they've actually differentiated two different subtypes of PTSD, which I thought was kind of interesting. So there's DPTSD, which people tend to overmodulate their emotions and tend to distance themselves from emotions, as opposed to patients who primarily suffer from re experiencing symptoms, including hyperarousal, intense feelings of shame, and difficulties in emotional downregulation. So, DPTSD people tend to be on the more numbing category, where the other type of PTSD may have a lot more in common with people with borderline personality symptoms. And I put the word symptoms on the end because it's so stigmatized to be diagnosed with borderline personality disorder. And, we really want to look at symptoms. What symptoms is the person having, and what function are those symptoms serving them right now? Where did they come from? What's going on? A lot of people in addiction recovery, for example, in early recovery, have a lot of emotional dysregulation and dichotomous thinking, and, a lot of characteristics of BPD. However, once they have some recovery time under their belt, a lot of those symptoms seem to remit some. So once they start to feel safer and more empowered in their situation. Personality disorders. So, PTSD is positively related to negative emotionality. Neuroticism, as we're using it, is one of those big five personality characteristics and refers to dysregulation, hypervigilance, or the degree to which a person believes the world is distressing, threatening, or unsafe. Well, if you've got PTSD and you're still experiencing those symptoms, then there's a good chance that those characteristics are going to be present. Harm avoidance, self transcendence, hostility, anger, and anxiety. So, as PTSD symptoms go up, these things go up as well. And a lot of these are actually kind of just synonyms for a lot of the PTSD symptoms, in my opinion. Now, PTSD symptoms are negatively associated. So, as these symptoms go up in PTSD, symptoms go down. They're negatively associated with extroversion, the ability, willingness, desire of a person to interact with others to get social support, conscientiousness, self directedness. So, being able to set goals and accomplish them, which helps people develop a sense of empowerment and self efficacy. High positive emotionality. So, as PTSD symptoms go down, mood goes up. Go figure. And hardiness, optimism, and hardiness is composed of three characteristics: commitment, control, and challenge. So, commitment refers to a person being able to look at not just one aspect, but broadly at their life and say, these things are important in my life, and I'm committed to all of these things. I'm committed to my job, to my kids, I'm committed to my pets, I'm committed to my hobbies. At any point in time, there's multiple things that they might be committed to, but they're going to recognize that they have a rich and meaningful life. And even though they might experience some distress, there's a lot more going on for them. So there's commitment and recognition, and maybe all their eggs aren't in one basket. Control is a belief or awareness of aspects of situations that you can and cannot control. So, someone recovering from a heart attack or open heart surgery, there are a lot of studies done with hardiness and open heart surgery. The ones who were able to view their life and say, okay, well, maybe I can't do this anymore because I had a heart attack, but all of these other things are important to me. And maybe I can still do this with modification. And that's important. I'm committed to those things. They recognize control. I can't undo the heart attack, and maybe I can't run a marathon anymore, or whatever it is that they did. They recognize that's out of their control, but what's in their control, following the recovery program, taking their medications, eating a healthy diet, all those things that they're supposed to do that can allow them to be able to engage with the things that are important to them, that they're committed to. The final C stands for challenge. Instead of viewing recovery from a heart attack or recovery from PTSD or life in general as an obstacle and overwhelming and oppressive, viewing it as a challenge, thinking, okay, that's fine. How am I going to do this? Having a more optimistic attitude and a more empowered and efficacious attitude is the third component of hardiness. And I think in cognitive behavioral approaches, there are a lot of these things that we can increase in people. Now, extroversion, a little note on that one: people who are temperamentally introverts are not going to want to be going to big support group meetings and everything. Extroversion for them might mean having one or two people that they're reaching out to and connecting with. So we do want to recognize and be sensitive to individual differences, but we can help people enhance their directedness, their ability to set goals, their self efficacy and self esteem, and those things that we can do that can help them enhance those levels of hardiness. And hardiness is kind of at the core of acceptance and commitment therapy, or ACT. Sleep dysfunction. So, 70 to 91% of individuals with PTSD report sleep disturbances. And that's a lot, especially since we know that sleep disturbances are directly correlated to HPA axis activation, increases in inflammation, difficulties with cognitive functioning, depression, and anxiety. So, sleep is important. The most common sleep disturbances in PTSD are insomnia, nightmares, and obstructive sleep apnea. So now this is where that gets interesting. So sleep disorders contribute to major depression, substance use, impaired daytime functioning, negative long-term health consequences, and suicide risk. And we don't want to minimize the sleep disorders. Insomnia may precede the trauma and predict the development of PTSD. So, people who had insomnia prior to the trauma are at greater risk of traumatic injury, of developing PTSD after exposure to a trauma, than people who are well rested and did not have insomnia. So, that's one of those things that we know is a risk factor that can actually, we can ask about. We can ask our clients about prior to the trauma. Did you have insomnia? Were you sleeping well? SSRIs and SNRIs, so selective serotonin and selective norepinephrine reuptake inhibitors, antidepressants, are commonly recommended as first line treatments for PTSD, but the effects of SSRIs or SNRIs on sleep are typically modest or even adverse since they disrupt REM sleep. So remember, you have three phases of sleep. You have light sleep, where you're easily awakened, you're just sort of dozing, REM, where you're dreaming, and deep sleep, in which your body's cleaning crew is going through it and cleaning out all of the adenosine from your brain and as much as those free radicals and everything as it can. Deep sleep is really important, but REM sleep does have a place. Benzodiazepines are not advised because of the risk of tolerance abuse and worsening of obstructive sleep apnea. Trazodone has been shown to promote sleep and reduce nightmares in PTSD and depressed patients, and may be particularly helpful for patients with concurrent PTSD, alcohol use, and obstructive sleep apnea. So, for some reason, trazodone, which is a serotonin agonist and reuptake inhibitor, doesn't seem to have the same effects on obstructive sleep apnea as some of the other medications. CPAP therapy, which is what they use with obstructive sleep apnea, has produced small but consistent decreases in PTSD severity at 12 weeks. CPAP therapy for people with obstructive sleep apnea has been shown to produce so many positive effects. It improves mood, reduces depression, it evidently reduces PTSD symptoms as well. It's also been shown to reduce inflammation and severity of autoimmune symptoms. So remember, with obstructive sleep apnea, people are basically stopping breathing multiple times throughout the night. And when you do this, your body's reaction says, crap, we're not breathing, you need to breathe. So that HPA axis, that stress response system, kicks into gear and, prompts you to start breathing again. It's like, hey, wake up. So people with obstructive sleep apnea, they're contributing to additional stress of the HPA axis on top of whatever traumatic stress. People with PTSD have a much higher rate of autoimmune disorders. If they're not sleeping well, that's going to contribute to inflammation. If they're stressed, we know that contributes to inflammation. If we have depression, well, we know that that causes inflammation or is a result of inflammation, but we know that the two co occur. So, autoimmune disorders, the main diagnostic feature is inflammation. So, people with PTSD do have higher rates of autoimmune disorders. They also have higher rates of coronary and cardiovascular disease, but it's interesting that it also works in the other direction. About 10 to 20% of people develop PTSD following acute coronary syndrome, so heart attack. Mainly, PTS symptoms increase the risk of adverse cardiovascular events as a result of dysregulation of the autonomic nervous system. So, all those things that we normally do automatically, like breathing and heart rate, are dysregulated to a certain extent with PTSD. Dysregulation of the hypothalamic pituitary axis, that HPA axis, oxidative stress, and inflammation. So PTSD really gets in there and causes, it doesn't just correlate, it increases the risk significantly of cardiovascular diseases, cardiovascular problems because of these physiological effects of stress. Addiction. And I want you to think about the paradox of trauma processing and substance abuse treatment as we go through this. Substances, behaviors can be used to self-medicate trauma or trauma symptoms. That's the first thing that a lot of us go to with addiction is, something of a self-medication hypothesis. Trauma affects the dopaminergic pathways in ways that largely mimic the effect of addictive drugs, causing increased dopamine release in the nucleus accumbens. So, what that's saying, even though in trauma people are not experiencing euphoria like they do with drugs, in trauma, when that HPA axis is activated, our body wants us to be motivated to fight or flee. So there's a dump along with glutamate, norepinephrine, and adrenaline of dopamine. So it's not as important as to why the dopamine is being dumped, but the fact that a bunch of dopamine is being dumped in the nucleus accumbens. So the same tolerance develops in PTSD as it does in addiction when we're dealing with, or when we're talking about the same neurotransmitter here. We're talking about dopamine. And regardless of why it's dumped, whether it's because of a traumatic experience or because of drug use, if the brain is bombarded with too much dopamine for too long, it starts becoming resistant. Another analogy that might make some sense, sometimes we talk about lock and key, and neurotransmitters are the keys and your receptors are the locks. And when there's too much dopamine going through, when locks are constantly being bombarded by the dopamine, eventually the lock stops to work. So there are fewer doors or dopamine to even go through. And that's kind of the body's way of saying, okay, we're really tired. We can't have all of this going through. We're just going to kind of shut down for a second. But it is interesting. Stress enhances the effects of drug related cues. Well, that makes sense because stress, just like trauma, increases the release of dopamine because we want to be motivated. Stress is kind of the garbage term for fight or flee, HPA axis activation. So, stress increases the amount of dopamine that's available, which makes people more aware of drug related cues. And when people are more aware of drug related cues, then the body says, oh, I remember that. And that was a good thing. So they start to have increased cue induced cravings, which can lead to a reinstatement of drug self administration. So, stress causes a little bit of dopamine to be in the body, and then it starts to be related to other things that remind them of when they had a whole lot more of dopamine, and it can lead to cravings. Repeated or prolonged exposure to stress can also recapitulate some of the core pathophysiology of addictions, including sensitization of the dopaminergic response, which is what we've been talking about, and having those locks stop working. The brain becomes sensitized to the effects of the key. So there's a paradox here. A lot of people with addiction have trauma, and a lot of people with trauma have addiction. Not everybody in either condition, but when you have somebody who has addiction and trauma, we know that trauma mimics the addictive and the dopamine release. So the question is, do you process trauma in people who are recovering from addiction? And some people might say, well, no. If stress is going to enhance their cravings, then processing trauma would add stress, so we don't want to do that. And in actuality, that's not correct. If the PTSD symptoms are still existing, if the PTSD is not under control, then the person already has stress. So when they're clean, they're going to have more cravings because of that underlying stress. So we need to help them deal with it, which is why concurrent treatment is so important. But it's also important to recognize that if you're working with somebody who is an outpatient in addiction recovery, that the timing of the processing of these things and how quickly you go through their emergency plans, we need to sort of plan this out very carefully because processing trauma can set them up for being vulnerable to relapse. Not to say that it shouldn't be done, it needs to be done. But ultimately, if it doesn't get processed, it often leads to relapse. But it's important to make sure that it's done with care, especially in outpatient settings where the person has access to their drug of choice. Psychiatric disorders that are comorbid with alcohol use disorders, such as PTSD, major depressive disorder, and other substance use disorders, may also have underlying neuroimmune mechanisms. So, neuroimmune mechanisms meaning targeting the immune system. And one of the things that they started to recognize is the cannabinoid 2 receptor, or your CB2 receptor, is one of the receptors in the endocannabinoid system that actually is mainly in the immune system. CB2 dysfunction is involved with mood disorders, and they're not sure exactly how, but they have known that when the CB2 receptors are not activated enough, it leads to problems, or when they're overactivated, it leads to problems. But they're also finding that substance use disorders, as well as PTSD and mood disorders, have neural immune underpinnings, and they're thinking that it may have something to do with the CB2 receptor. We do see more abuse of benzodiazepines in people with PTSD. Benzodiazepines are your anti anxiety medications like Xanax or Valium. PTSD, people tend to have anxiety, so it makes sense that they might be self medicating. And unfortunately, the benzos are extremely addictive and sometimes used in certain populations to enhance sleep and reduce insomnia. But as we mentioned earlier, there are options that seem to be a lot more effective. And so we just want to have less risk of adverse outcomes. So, we just talked a whole bunch about PTSD. The next one in the chapter is acute stress disorder. And I put this graphic here because, they're very, very similar. The real difference here is onset, duration. The symptoms are a little bit different, and the treatment is short term versus long term. So, I think that this graphic actually summarizes it a lot better than me just talking at you and telling you the same things all over again. So, adjustment disorder. This is one that's commonly diagnosed in counseling. And I know that we've been joking about, like, if you can't figure it out, this one's a safe bet. This is the case in which emotional or behavioral symptoms are a response to an identifiable stressor or stressors. In this case, the stressor might be a single event, loss of a job, death of a loved one, a financial situation, or continuous reoccurring stressor like bankruptcy, or somebody's house burned down and they're dealing with insurance and rebuilding and getting all new stuff, and homelessness, maybe, or maybe romantic relationships that just aren't going that well. And there can also be multiple stressors that call for a diagnosis of adjustment disorder. So, unlike PTSD, in which there are very specific symptomology, adjustment disorder is literally due to the adjustment of a stressor and the person's work to get back to their baseline. Now, adjustment disorder is a time limited diagnosis. You're on the clock with this one. The symptoms of adjustment disorder must begin within 3 months of the stressor and within 6 months of the termination of stress or the consequences of the stressor. So we think about the consequences. Think about something like I mentioned before, like a house fire. The house burns down. The family's dealing with the insurance agency. The house is being rebuilt. The idea is that 6 months after the stressor is complete, after the house is rebuilt, everybody's back living together, that the symptoms of the adjustment disorder would taper off. If the stressor is persistent, such as long term unemployment, then symptoms may also persist longer. This is commonly used as people oftentimes seek counseling because of a stressor in their life. In addition, adjustment disorder can be with depressive symptoms, with anxious symptoms, or with both. You'll see that as you read through the DSM. And as far as prevalence and symptom severity, symptoms must be more severe than they would typically be observed in a person's reaction based on their age, gender, and culture. And the impairment must be significant to be diagnosed with adjustment disorder, and approximately 5 to 20% of individuals presenting for outpatient treatment have their primary diagnosis as adjustment disorder. Prolonged grief disorder is a new disorder addition in the DSM 5 TR. It's not in the DSM 5. So if you're working from the 5, you probably won't even see this one at all. But after studies over several decades suggested that many people were experiencing persistent difficulties associated with bereavement that exceeded expected social, cultural, or religious expectations, the DSM decided to add it. So grief is a natural response to the loss of a loved one. And for most people, the symptoms of grief begin to decrease over time. However, for a small group of people, the feeling of intense grief persists, and the symptoms are severe enough to cause problems and stop them from continuing with their lives. Prolonged grief disorder is characterized by this intense and persistent grief that causes problems and interferes with daily life. The individual with prolonged grief disorder may experience intense longing for the person who has died or preoccupation with thoughts of that person. In children and adolescents, the preoccupation may focus on the circumstances around the death. Additionally, the individual may experience significant distress or problems performing daily activities at home, work, or other important areas. The persistent grief is disabling and affects everyday functioning in a way that typical grieving does not. For diagnosis of prolonged grief disorder, the loss of a loved one had to have occurred at least 1 year ago for adults and at least 6 months ago for children and adolescents. In addition, the grieving individual must have experienced at least three of the symptoms nearly every day for at least the last month prior to the diagnosis. So these symptoms are identity disruption, marked sense of disbelief about the death, avoidance of reminders that the person is dead, intense emotional pain, difficulty with reintegration, emotional numbness, feeling that life is meaningless, and intense loneliness. In addition, the person's bereavement lasts longer than it might be expected based on social, cultural, or religious norms. And I guess the DSM is saying that for adults, you can have all of this up to a year, but if you go a year and a day, then you meet criteria for this diagnosis. But a year is totally normal. I don't know about that. But again, they're using that marker of a year. So, an estimated 7 to 10% of bereaved adults will experience the persistent symptoms of prolonged grief disorder. Among children and adolescents who have lost a loved one, approximately 5 to 10% will experience depression, post-traumatic stress disorder, and or prolonged grief disorder following bereavement. So, to summarize, I don't even know where to start for you right now. I feel like I hit you with a ton of information. The key points to remember when thinking about this chapter are really considering your fight, flight, HPA axis activation and how it works, how it impacts the brain and the body long term, and how symptoms of disorders can develop due to prolonged activation. Your role as a counselor, do what you can do to help tap into rest and digest or that parasympathetic nervous system, which we didn't really talk about today. Grounding, meditation, mindfulness, CBT, EMDR, and polyvagal theory are all great places to start.